Greetings, everyone, and welcome to the IFAM Thursday Seminar Series. This seminar is held in partnership with the Buehler Center for Health Policy and Economics. One housekeeping thing before we start, which is we're not monitoring the chat during this talk. We will be taking questions in the Q&A for discussion at the end of the talk. So if you have a question, please put it in the Q&A and I will monitor that. And with that, I want to introduce our speaker today, Hannah Neprash. It's my great pleasure to welcome her on a topic we're, I think, pretty interested in here. Dr. Neprash is a health economist with research on the delivery and financing of healthcare. Especially as the expense and complexity of American healthcare continues to grow, Dr. Neprash works to build a more efficient and resilient healthcare system. Her research studies new threats like cyber attacks in healthcare, persistent challenges, including public insurance reimbursement, design, and emerging opportunities. For example, artificial intelligence in medicine. She's received awards for her research, including the Academy Health Publication of the Year Award in 2021 and the 2024 University of Minnesota McKnight Presidential Fellowship. She is currently an associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. And she has experience in federal and state health policy, including spending time with the Medicare Payment Advisory Commission and the Health Subcommittee of the U.S. House of Representatives Ways and Means Committee, and the Massachusetts Health Policy Commission. She holds a PhD in health policy from Harvard and a BA in economics from Oberlin. So please join me in welcoming Dr. Neprash for her talk today. Over to you.
Thank you so much, Marianne. And it's a pleasure to be here, especially so late in the semester. I really appreciate everybody attending. Let me go ahead and share slides. All right, with any luck, you are seeing a title slide. I will do my best to save at least 10 minutes to the end for questions. So I want to start with acknowledgements, of course. I want to thank my two wonderful co-authors, my colleague Saya Nikpay, and a phenomenal doctoral student here at the University of Minnesota named Claire McGlave. Also a small army of research assistants. I'll tell you what they did in a couple of minutes, and funding from the NICM Foundation and HRSA as well. So I used to open this talk by polling the audience to see if anybody had heard of this thing called a cyber attack on hospitals. And of course, in 2024, it's such a ubiquitous phenomenon that no longer makes sense. 2024 alone has seen a couple of very high-profile attacks. The first was in February on a company that none of us had heard of until the attack happened, called Change Healthcare. And when this cyber attack struck, suddenly a large chunk of hospitals and doctors in the US could not get paid because it turns out that Change Healthcare handles reimbursement for a good swath of the US healthcare system. In May, you can see the coverage in the Washington Post of the second very large attack that happened on Ascension Health, the country's fourth largest hospital system. This affected 140 hospitals in at least 10 states. And okay, there we go. Of course, cyber attacks are a national phenomenon, but I know they're also a very local one. In January of this year, there was a cyber attack down the street that was pretty severe. It disabled a lot of electronic systems, scheduling, medical records, other functionalities. I I would love to learn from any of you who experienced this firsthand, because this can be a very academic topic, and of course it affects real people. So I've been talking about cyber attacks, but that's an umbrella term, and I want to get a little bit more specific here. So today we're talking about ransomware attacks, and this is actually what happened to Lori, and it's what affected Ascension and also Change Healthcare. It is by far the most common form of cyber attack that we see in healthcare these days. So here's a working definition of a ransomware attack and an homage to what is called the blue screen of death. I'm sure we've all gotten it. This is usually what you see at the beginning of a ransomware attack when you realize that you're in this situation. So during a ransomware attack, cyber criminals, hackers, infiltrate an electronic network. They install malware to prevent users from accessing their systems, and they demand a ransom to restore access to either data or electronic systems. The ransom themselves is the payment, if an organization chooses to make a payment, is usually in an untraceable cryptocurrency. So we're talking Bitcoin or Ethereum. Those are the most common ones. And ransomware attacks are unusual for health economists to study or for a health services research audience. But this topic really caught my eye because ransomware attacks disrupt care delivery. This is very much by intent. The more disruption they cause, the more likely a victim is to pay a ransom and to pay the full demand. So in the context of hospital ransomware attacks, we see some common disruptions to care. The most common is electronic health record downtime. Of course, when the EHR is down, it forces a switch to old school documentation with pen and paper. But it's usually accompanied by downtime for a couple of other electronic systems as well. So it's common to see electronic prescribing systems go down, and it's also pretty common to see imaging equipment and lab testing equipment either inaccessible or you just can't get the results out. They can't be transmitted to the electronic medical record. Another common disruption is that a hospital is unable to verify a patient's insurance status. Frequently, you might see prior authorization requests and approvals disabled, and so it's not uncommon to see care get canceled. Frequently, these are cancellations of scheduled surgeries, sometimes outpatient care as well. And the least common, though unfortunately it's becoming more frequent, disruption that we see during a ransomware attack is, of course, ambulance diversion. Diversion is usually something that facilities choose to go into when there is a crowding situation. Diversion is a decision that facilities might make during ransomware attacks when they simply don't have the capacity because they've lost a variety of these other systems to provide safe and effective care. Okay, so if this feels a bit abstract, I've pulled a couple of quotes from clinicians who have been working at hospitals during ransomware attacks. So this is a nurse who said, described the situation. As of now, we have no access to any patient files, history, nothing. Doctors aren't able to access any type of x-rays or CT scans. Another quote from a completely different hospital ransomware attack. When the laboratory had a critical lab result on someone, they couldn't put it in the electronic medical record. They couldn't call the floor. And so we literally had our administrators start going in the lab, standing there and running paper results to the floors. I did some digging and I found a quote specifically from the Lurie attack because I wanted to see if there were clinicians who had talked about that. And there were. Not only do we not know what they're coming in for, who's coming in, when they're supposed to come in, we have essentially no information about them. Talking about scheduled care here. There was a time where we would have our paper charts still. We don't have that anymore, and we're prepared for this to happen for a couple of hours or for half a day, but for it to go on for days on end is really hard. So the research question for today's talk, I think is deceptively simple. I'm asking how ransomware attacks affect hospital operations and health outcomes for patients. The effect on hospitals is pretty clear. When a ransomware attack hits, it's a negative capacity shock. Hospitals can't provide the same level or quantity of care that they otherwise would in the absence of a ransomware attack. I would argue that the effect on patients is a little bit more ambiguous, and you have to stick with me here. There is absolutely a potential for lower quality care, resulting in worse outcomes for patients. And I think the textbook example here would be cardiovascular emergencies, where delays in care, of course, have severe implications for survival and other outcomes for patients. More broadly, there's also a potential for harmful drug interactions, missed diagnoses, other consequences of not having access to the usual electronic systems that we rely on in healthcare. But of course, we know that we have a massive amount of waste and overtreatment in healthcare, and there's a large literature in health economics showing us that more intensive care isn't always better. It doesn't always translate into better outcomes for patients. So this is a challenging research question to answer for a few reasons, but the one that we had to tackle first was the fact that there just isn't systematic data collected on who goes through a ransomware attack. So the first thing we did for this project was actually create our own data. This was my first experience creating a data set. It was an interesting one. The data set that we created is called the Tracking Healthcare Ransomware Events and Traits Database, the threat database. And if you're interested in the kind of the nitty-gritty details of this data resource, or maybe you want to use it, please feel free to email me. I've also put some citations for some of the descriptive papers that we've published using this database. In brief, the threat database pulls information from a couple of sources. So it pulls public information from the US Department of Health and Human Services that collects and publishes a list of data breaches that affect HIPAA-covered entities. So this is going to be what's called the wall of shame, wherein if patient health information is exposed, an organization has to report it to HHS, and some of those details wind up becoming public. We combined that with some proprietary information from a couple of companies that provide threat monitoring services and other kind of cybersecurity defenses. And what they were able to share with us were lists of cyber attacks. These were frequently across a lot of industries, and so we supplemented these three data sources with manual data collection, going through local and national media coverage of ransomware attacks, going through some press releases. Frequently, organizations will announce or try to keep the public updated, and also public disclosure letters that are required by different states. So at the end of the day, we are working with data on 136 ransomware attacks that affected a total of 571 US hospitals. Okay, so here you can see the annual count of ransomware attacks affecting US hospitals. You can see that, of course, the number of attacks are increasing over time. I will say it's no accident that you see this jump in 2020. It was a very intentional decision on the part of a couple of large cyber criminal organizations to really target the healthcare sector during the COVID-19 pandemic, knowing that this was a sector with fairly deep pockets and also a sector of the economy that was distracted trying to deal with a novel pandemic. So you see the jump in 2020, and it continues. From 2016 to 2023, the number of attacks increased a little bit more than twofold. But the number of hospitals that experienced ransomware attacks went up even more. So the ransomware attacks themselves are getting bigger. They affect more hospitals in any given attack. So from 2016 to 2023, we saw more than a fourfold increase in the number of hospitals experiencing these attacks. 2024, we still have incomplete data, but it's on track to be the year with the greatest number of hospitals experiencing ransomware attacks. All told, from 2016 to today, we have a total of 571 short-term acute care hospitals in the US that have gone through a ransomware attack. And this is about 12% of all US hospitals that have been in this situation since 2016. Okay, so ransomware attacked hospitals differ from non-attacked hospitals in a couple of interesting ways. First of all, they're bigger. They are also more likely to be located in urban areas. They tend to be affiliated with a larger health system. They're more likely to be a level 1 or 2 trauma center, more likely to operate an emergency room and an obstetric unit. You might think that attacked hospitals would be the more vulnerable ones because their IT systems are not quite as developed, but we actually see very similar characteristics when we look at IT sophistication and capabilities. So it doesn't look like this is a story about who's more vulnerable. It looks like a story of targeting. And this is actually, this lines up with what the warnings coming out of the FBI saying that cyber criminal groups are specifically targeting large players, the big fish in healthcare, probably because they can afford to pay larger ransoms. And the fact that they're targeting organizations with trauma centers and ERs and obstetric units suggests that maybe they're going after places where disruptions to care delivery are have more severe consequences for the patient populations and the type of services that are delivered there. Okay, so for this project, we are linking our list of ransomware attacked hospitals to Medicare fee-for-service claims data in order to study 3 categories of dependent variables. The first is hospital operations. So here we have patient volume and Medicare revenue in 3 different settings: the emergency room, inpatient, and outpatient settings. Then we have some measures of hospital case mix so that we can look at whether the types of patients admitted and seen are different during a ransomware attack. And finally, we have a couple of the usual suspects in terms of health outcomes when you're doing research with claims data. And here they are: mortality and also 30-day hospital readmission rates. So the empirical approach we're using is something called a stacked event study. The intuition here is that we can exploit the staggered timing of ransomware attacks in order to identify the effect of these attacks on hospital operations and patient outcomes. So I've tried to visualize this a little bit for you. This is the timeline on the bottom, and it plots some of the larger ransomware attacks that have affected hospitals between 2016 and 2024. For each of the 136 ransomware attacks we have, we construct a data set using Medicare claims data where we look at the 5 weeks before the attack and the 5 weeks after. And then we take all of these 10-week chunks and we basically line them up so that we have time becomes a relative thing, and we're looking at outcomes relative to the ransomware attack itself. And there is a pretty strong assumption in this research design. The assumption is that hospitals themselves can't predict attack timing. We've done a couple of things to try to reassure ourselves that that this assumption is fair game. Of course, any assumption is hard to, you know, hard to necessarily prove, but I can, at least right now, I can sleep at night on this one, for two reasons. The first is that we've regressed the calendar week of the attack on a whole host of time varying characteristics of the hospital, volume, revenue, case mix, mortality rates, everything. And we can't find anything that predicts when the attack occurs. As further evidence, just a kind of a qualitative data point, there are some surveys of large health systems and how frequently they experience attempted cyber attacks. Attempts are usually phishing emails, and the average large health system says that they get more than 1,000 attempted cyber attacks a week. So that is a staggering number, and it's hard to say necessarily when any of those attempted cyber attacks will hit. You know, when somebody will have the misfortune to click a link that they shouldn't, and that's enough to start to give bad actors access to a system. So there's one more methodological consideration that I have to tell you about before I show you results, and that is selecting a comparison group. So in this analysis, the treatment group is pretty obvious. The treatment group is those that, you know, the list of almost 600 ransomware attacked hospitals. The comparison group is a little trickier because we're concerned about spillover effects. I told you that one common disruption is that a hospital will go into ambulance diversion. That is, you know, by definition, a spillover effect on the other hospitals in the market. Because ambulances will take patients elsewhere. So we do a couple of things. Our first comparison group is a group of non-attacked hospitals matched on a variety of characteristics so that they look similar to ransomware attacked hospitals, but they have to be outside the hospital's immediate market so that they're not subject to any of those spillover effects. Our second comparison group is that we use ransomware attacked hospitals as their own controls prior to the attack. And this is an approach that's common in the economics literature, but it's a little tricky here because attacks are not distributed evenly over our time period. They're becoming more frequent towards the end. So using future attacked hospitals is a strategy that winds up throwing out some of our data. But the results I'll show you use both of these comparison groups and tell essentially the same story, regardless of the comparison group that we choose. All right, so I am going to start with hospital operations as the first set of results, and I'll show you some event study plots now. All right, so this is starting with emergency room volume and Medicare revenue. And I want to look first at what happens before the ransomware attack. So everything to the left of that dotted red line. Before the attack, estimates are statistically indistinguishable from zero, meaning that there's no difference, there's no systematic difference between ER volume at attacked versus comparison hospitals. This is reassuring to see because it supports this assumption that hospitals can't predict the timing of ransomware attacks. Now we can look after that dotted line. And what we see is that emergency room volume falls precipitously in that week 0, which is the first week of the ransomware attack. ER volume falls by 17%, and ER revenue falls by almost 40%. And you might be wondering, why does revenue fall so much more than volume? Some of it is mechanical. Obviously, there's less revenue if you're seeing fewer patients. But some of it is also what we're seeing is that there's less intense treatment for the patients that are seen at these ransomware attacked hospitals. The share of high intensity emergency room visits actually falls by 10%, and they're just doing fewer services for them. This is a big change. It's pretty hard to find something comparable to something else that causes a shift in volume of this magnitude at this pace. Just to give you a sense of scale, this result here is about half the volume drop that we saw on average at hospitals during that first month of the COVID-19 pandemic during lockdowns. But it's a big change, but it's also a really temporary change. So we see that on average, hospitals recover to their pre-ransomware attack volume within 3 to 4 weeks. So now I'm showing you inpatient admission volume. And we see a similar pattern here. Inpatient volume falls by 18%, revenue falls by 21%. Recovery happens again pretty quickly, even maybe a little bit faster. It looks like it's about 2 weeks. And I can tell you that the reduction in overall inpatient volume is driven by a reduction in non-elective admissions, specifically a reduction in admissions for AMI and stroke, which is consistent with this story about fewer admissions for conditions where patients usually or are more likely to arrive by ambulance. So there are fewer ambulances coming to these hospitals, and there are fewer patients who are being seen for heart attacks and stroke, and a couple of other acute cardiovascular emergencies as well. The last picture I want to show you on the operations front is outpatient volume. And here again, we see a reduction. Volume falls in that first week of the ransomware attack by 26%, revenue falls by 19%. And we can dig a little bit more into exactly what they're doing less of. We use a classification scheme called BTOS codes, Berenson Eggers coding, to classify all possible HCPCS codes into types of services. And what we see is that the overall pattern here in this picture is driven by a much larger reduction in the use of imaging services and in the use of lab testing services. Patterns which are, again, consistent with some of the disruptions that we see during ransomware attacks when hospitals lose access to imaging systems and other testing infrastructure. So we repeat our event study analysis at the market level too. And we do this because comparing hospital results to market results is going to tell us something about the spillover effects. So if a hospital and a market look exactly the same during a ransomware attack, then there's essentially no spillover effect, but that is not what we see. During ransomware attacks, the average hospital sees a reduction in emergency room volume of 17%. But looking across their entire market, we actually don't see any change in emergency room volume. So this tells us that other local non-attacked hospitals are essentially picking up the slack. They are seeing more patients when the attacked hospital or hospitals can't see quite as many. We do see market level reductions in inpatient and outpatient volume, but it's considerably smaller than the effect for individual hospitals. So again, suggests that there's some spillover here. And then when we look at case mix, I told you that ransomware attacked hospitals really reduce their census of AMI and stroke patients. And at the market level, we don't see any change in the number of patients with AMI or stroke diagnoses. So taken together, these results are telling a story wherein nearby hospitals are absorbing some, but not necessarily all, of the displaced patient volume during ransomware attacks. All right, so now we are coming to the patient outcomes side of things. So talking about mortality and readmission rates. But first, I have to drag us back into one more methodological consideration. And that is that when we're talking about mortality, an event study doesn't quite work. Imagine that you observe a hospital in the week before a ransomware attack and the week after a ransomware attack. Every patient admission is different. So let's see, here we have patient A. They're admitted and discharged before the attack even starts. Patient B is also admitted before the attack starts, but they're still there when the attack hits. So they're exposed to whatever disruptions happen during a ransomware attack. Patient C is admitted and discharged in the week after the attack, so on and so forth. What I'm showing you here, it should help illustrate two problems. The first is that hospital admissions frequently span multiple weeks, making it really hard to assign admissions to a relative event week. But more importantly, simply counting the number of patient deaths at a hospital in the first week of a ransomware attack is going to conflate two distinct groups of patients. Those who were already admitted when the attack hit and therefore were exposed to the effects of the attack, and those who are admitted after the attack starts, who are probably going to be different in ways that we can observe and ways that we can't observe. Okay, so how do we solve this problem? We solve it by doing, instead of an event study, we're going to do an admission level difference and differences analysis, limiting to patients who were admitted before the ransomware attack. And this is a very intentional design to avoid selection here. We know that hospitals are trying to change their case mix after a ransomware attack. They're trying to make sure that the folks with time-sensitive acute cardiovascular conditions are getting care. So by avoiding the patients who are admitted after the attack starts, we're hopefully going to have less of a dimension for patient selection here. So difference and differences, we have two differences here. The first is that we're comparing admissions at attacked hospitals that are going through ransomware attacks, versus hospitals in the comparison groups. And again, we're using those two comparison groups of matched controls and also admissions at hospitals that have not yet, but will go on to live through a ransomware attack. The second difference here is before versus during ransomware attacks. So we are comparing patients who were admitted and discharged in those 5 weeks before the attack started to patients who were admitted and were still hospitalized when the attack hit. So before I show you results, I want to show you some mortality rates at control hospitals versus treatment hospitals. And again, treatment hospitals here are the ones that are going through ransomware attacks. And this is an incredibly noisy picture. It's really hard to tell these time series apart, and that is great. There's basically no daylight here. The average mortality rate, for anybody admitted on any of these days in the 5 weeks leading up to a ransomware attack, about 4% of hospitalized Medicare patients will die. That is a high rate, but of course, we're talking about a Medicare fee-for-service population here. So these are older adults and sicker than the average patient population. And the fact that this is so stable and these series overlap really supports this parallel pre-trend assumption that's needed for a causal interpretation of what I am about to show you. All right, so here I am showing you that interaction term from difference and differences models, two identical models where we're just using different control groups. And what we see here is a differential increase in in-hospital mortality that ranges from 1.24 to 1.38 percentage points without any differential increase in 30-day readmissions. So for patients who are hospitalized during a ransomware attack, the likelihood of in-hospital mortality goes up significantly. As a relative change, this is between 36 and 41%. Because mortality is still, around the 3.5–4% mark on average in the pre-period. But for those patients, if they manage to walk out of the hospital, there's no change in the likelihood that they come back. So whatever's happening to them is happening in the hospital. The next thing we do is that we repeat this analysis with a subset of our ransomware attacks. We want to focus specifically on the most disruptive ransomware attacks that we know of. And we do that by identifying the group of attacks where news coverage suggests that they either had to cancel surgeries in response, or sometimes they had to divert ambulances. So these are the attacks where the operational disruptions were so severe that they really, really changed business as usual. And as you might expect, we see bigger mortality effects for this subset of very severe ransomware attacks. Now the increase in in-hospital mortality is more in the 40 to 50% range. And the last subset that I want to tell you about is that we look at, we try to focus in on the patients who are the sickest. So again, we're looking specifically at a Medicare population, which is already going to be a sicker than average population, but we can focus on the sickest folks within that in a couple of ways. The first is by identifying people who already had at least 3 chronic conditions recorded before they even were admitted to the hospital. The second way is by looking at patients who are admitted specifically to the ICU. And in both groups, we find larger increases in mortality during ransomware attacks. I should say that it's really hard to disentangle what exactly is happening, right? Whether this is due to disabled equipment or disrupted, complicated treatment plans. It could be medication errors. It could be something entirely different. Unfortunately, the fact that we're working with administrative claims data means that it's really hard to kind of get under the hood. And this is a limitation because it would be, it feels very important to be able to understand exactly what is going wrong for these patients. So I want to tell you about a couple of next steps on my list, though of course I hope that people will add to my list here. The first is that we want to look for spillover mortality effects. So we know that ER volume especially goes up at neighboring hospitals. Crowding may very well increase or harm patient outcomes. And so I think it's important to look at that. I also want to look at market level changes in travel time because we know there's a lot of diversion happening, and market level changes in mortality specifically for AMI and stroke, because these are the patients that are going to facilities that are potentially further away. They're going to places they wouldn't otherwise go to when their typical hospital is in the throes of a cyber attack. The other thing that's on my to-do list is to test for some longer term changes in hospital quality following a ransomware attack. So of course, right now we're focusing really on the 5 weeks before and after a ransomware attack. But that's a very short time horizon. And these, because of the operational disruptions I showed you, ransomware attacks are pretty large financial shocks for hospitals. And so it's possible that in the wake of a ransomware attack, they have to essentially make budgetary decisions that may have the end result of harming quality of care at the facility. So that's something that I'm looking to do next. But there are, I think, three takeaways of the research that I've told you about today, for me at least. The first is that it's abundantly clear that ransomware attacks are tremendously disruptive and costly for hospitals. Um, the disruption only lasts for about 3 to 4 weeks, but because it's such a big disruption in volume and revenue, those 3 to 4 weeks amount to a loss of about 1% of annual operating revenue. If this seems small to you, I will tell you that the median hospital has a profit margin in the low single digits. So this is actually potentially the difference between a year in the black and a year in the red. And if it seems large to you, I will tell you that this is probably actually a lower bound. We can't see any money that's spent on recovery or investigation, or frequently there are class action lawsuits that follow a ransomware attack, or on improving cybersecurity. So likely the total cost of this type of cyber attack is considerably larger. So the second takeaway for me is that ransomware attacks really don't, these aren't isolated events. They are affecting the entire hospital market because we see these really clear spillover effects when we compare the hospital level results to the market level results. And this is a big deal because, you know, this is still a relatively uncommon event. 12% of all US hospitals have gone through this type of experience. But if you look at the number of hospital markets where there has been a ransomware attack, it's more like 50%, even a little bit higher. And so if you think about this as a market level phenomenon, because of those spillovers, because of the ways that nearby non-attacked hospitals have to absorb some of the displaced patients during a ransomware attack, it becomes a much more widespread phenomenon. And then finally, there's evidence that patient mortality goes up during ransomware attacks. The most severe attacks are the most harmful, and the sickest patients are the most harmed by these events. So for me, this suggests essentially twin policy goals of both prevention and preparation. By prevention, I am talking about investments and policy changes that would specifically incentivize cybersecurity improvements. It's within recent memory that healthcare was kind of dragged kicking and screaming into the 21st century, and an unintended consequence of digitizing everything and becoming so reliant on a variety of very complicated and interconnected electronic systems is, of course, that they are vulnerable to cyber attacks like these. And hospitals currently, they can voluntarily make investments in cybersecurity, and there are kind of accepted best practices, but the amount of dollars that actually go towards cybersecurity investments are still very low. In part because, this is a highly regulated industry, and, if you spend $1 on cybersecurity, you're not spending it on something else. And so one of the policy changes that I think will happen possibly later this year, but at least in the next year, is that we'll see minimum hospital cybersecurity standards imposed. Essentially try to get everybody up to the same minimum cybersecurity bar. These are things that I bet we're all used to, things like multi-factor authentication and email security, encryption, network segmentation, a couple of other things. And I think, setting any sort of mandated cybersecurity actions will involve subsidies for under-resourced hospitals, because this will be harder for smaller and rural and safety net hospitals to make these investments. So that's the prevention, but I think that preparation is also important here because we will never get the number of cyber attacks down to zero. It seems very likely that we will be able to prevent these, and the harms from them are real and are large. And so I think in terms of preparation, we need to really incentivize what's called incident response planning. Um, some of that happens already, but usually this is the purview of um, IT professionals, and they should absolutely be involved. But I think that this requires more clinician involvement too, and should explicitly, incorporate research findings in order to prioritize patient populations that we know are particularly vulnerable. So, for example, we know that patients in the ICU, that's where we see mortality effects really concentrated. So, how can we make sure that if there is an incident, like a cyber attack, that electronic systems that relied on specifically for ICU patients are the ones that are prioritized for recovery. Um, to further complicate an already hard task, I would say that incident response planning should ideally happen at the market level, because we know that when a cyber attack hits one hospital, there are spillover effects for their neighbors. But of course, those neighbors are all competitors, so it is pretty tricky to get hospitals in the same market who are used to competing with each other for market share and for patients to instead work together to develop plans and how they will respond in the event of the next cyber attack. But certainly, you gotta dream big. So that is all that I have. Thank you so much. I've saved, it looks like 12 minutes for questions. I put my email address here too, just in case there are other things that come up afterwards. I will stop sharing my screen, and I would love to hear from folks.
Well, thank you so much. That was such an interesting presentation. I hadn't thought about the spillover effect on hospitals that were not part of the directed attack, so something to consider. So we have two questions in our Q&A. The first one is from Dr. Lindsay Allen, who says, great presentation. Can you offer any insight on how your results might hold or differ in other patient populations? And she gave the example of non-dually eligible Medicaid enrollees.
Yeah, thank you, Lindsay. I think that's a really good question. We have been looking a little bit to try to see, if there are other patient populations where the effects are really concentrated. And I agree that patients from historically underserved groups are a natural place to look. We don't find larger effects for duals. That doesn't necessarily rule it out, though. I think that the other really important thing, for me at least, and obviously, it all comes down to data challenges, but I would love to look beyond the Medicare population, because it's a pretty selected population. There, possibly in the next couple of months, we should have access to Medicaid claims data, so we could get at your question a little bit for kind of from a different angle. But then also commercial claims data would allow us to look at some other patient populations where electronic systems are especially important. And here I'm thinking of labor and delivery services. That might be, it's certainly a high volume thing, and it's one where there are a lot of systems involved. And so that might be another place to look for disproportionately harmed patients in a hospital setting. I'm open to other suggestions too.
Well, thank you. We have actually three more questions now. So this is from an anonymous attendee. Apologies if this was already covered. They had to step away for a moment. How does the cost of paying the hackers fold into the conversation? I work with community centers, and recently a system was hacked, and interestingly, they were sent a complete report from the hackers as to how they infiltrated their system, what their vulnerabilities are, etc. and the cost of paying them was significant.
Yeah, it's a good question. The short answer is I don't know, and basically nobody knows. That is probably one of the most closely guarded secrets. So it's kind of only been, it's only as cyber attacks become more common, it is easier to talk about in the healthcare system. But there is very little reporting or disclosure of who pays and how much. Um, according to the FBI, the amounts are going up, but there are some other kind of tricky dynamics happening. It's becoming more common that a hospital will pay a ransom and expect to, regain access to their systems, only to have another ransom demanded. So that is kind of this like double ransom situation. The from a law enforcement perspective, I am not law enforcement, so I'm kind of just speaking to what I've heard from FBI folks. They frequently get the call when a ransomware attack is discovered, and they try to encourage places to refuse the ransom. That is the goal. But in healthcare, it's really hard to do that because this is quite literally a life or death situation. And so you see that ransom payment seems to be higher in the healthcare industry compared to other industries like the financial sector or manufacturing. And potentially that is because the consequences are just considerably more dire. Yeah. But it's
Uh,
interesting, the idea of this like readout from the hackers themselves about how they got in. I've never heard about that. And that, I mean, that's oddly helpful. Huh.
yeah, I actually was wondering about the purpose of them sending that. I guess it's something that could be shared. Um, I'm not sure. We have another question from Bing Chang. Was there a correlate to the AMI stroke in the pediatric hospital settings?
Hmm. Um, Another great question and another limitation, I think, of the Medicare data. I would be very curious if you have suggestions for what we should look at when we repeat this in Medicaid claims and commercially insured claims as well. Yeah, thank you. It's a good question and a very Lurie specific one. Yeah, I can see why that is on folks' mind.
Yeah, and he had a follow-up asking, or maybe pediatric hospitals were excluded from that analysis.
Yeah, they are excluded from the analysis right now, mostly because we just have very little insight into what's happening. Yeah.
Okay. Was Lurie the only pediatric hospital included in these attacks?
There are a couple other ones. Lurie is by far the largest pediatric hospital attack that has happened and the most disruptive. Yeah.
Okay. Okay. Well, that ties up our questions for today. I'll just give, if you don't mind, give one more moment for people to uh, send in something they have. As you know, this is recorded and goes onto YouTube, so it will live on. And oh, we do have one more question. This is this is from the person who sent the question about the community health center attack. And she says, I think they sent a report because it was a community health center system serving marginalized communities. And the hackers, oddly enough, had some morals or sympathy for that type of system. That's really interesting. And this person, Sarah Ritter, has offered for us to give her information to you if you would like to connect on that.
Yeah, thank you. I appreciate that. And it's actually not the first instance of kind of this uh bad actors having a strange good side. There have been some there were a couple very high profile ransomware gangs, for lack of a better term, organizations that actually kind of banded together and said, we won't attack healthcare facilities, and we won't attack specifically safety net hospitals. I have no idea how they were defining that. During the pandemic, and some of this cooperation has broken down. So anyways, thank you. I will follow up on that. I really appreciate that.
Okay, I will send an email to follow up. Well, thank you so much for your insights and knowledge. It's been really interesting, and um, I, I was actually texting with a colleague during this, and she said, "Oh, her way of explaining methods is brilliant. You know, it's so simple and so clear." So we appreciate you for that, and thank
Thank
you
you.
for joining us today.
Well, and I really appreciate the feedback and the chance to share this result. Thank you.
Great. Take care.
Bye.